Hello and good afternoon to everybody, to all the assistants to this new MBA On Air webinar. Sorry for the small delay because we have problems with the direct, but now here we are. We are today to attend the presentation that will be done by Dr. Sanjay Harhangi from the Netherlands on transforaminal lumbar spine endoscopy. Dr. Harhangi, who was born in Suriname, he has had all his education in the Netherlands, in the University College in Arnhem, in the Radboud University. He has a Master also of Science in Clinical Epidemiology in the Erasmus MC Rotterdam, and he has his resident neurosurgery in the same hospital, and also his current work of neurosurgeon in this hospital. As consultant, his main responsibility is for adult neurosurgery, and the main interest is spine and craniocervical junctions, also oncology and arteriovenous malformation. He's one of the pioneers in endoscopic spine activity in the Netherlands. And regarding projects and research, he has a lot of publication, but maybe the most important is the recent one, as is the biggest controlled randomized trial with more than 700 patients comparing endoscopic surgery with traditional surgery, and that maybe will publish at the end of this year. We were looking forward to have him in March in NeuroRakis in Hospital La Paz in Madrid, but was not possible due to the COVID, so we are very proud to have him today on the MBA On Air webinar. So thanks, Dr. Harhangi, and please go ahead.
Thank you so much for this kind introduction. I hope you all are doing well. Unfortunately, the talk is on this webinar, and hopefully we will have a good communication. And I think if you have any questions, you can ask them during the presentation, but also after the presentation is possible. So today I want to talk with you about the percutaneous transforaminal endoscopic discectomy, and especially the outside-in technique. There are several ways you can perform endoscopy, but it's all about innovation. And if you look at our hospital, this was in the early 60s, where we had one of the most modern hospitals of Europe, and now it became very old. And we are looking at new innovations in our hospital, and we have built a new hospital, which is shown like this. So that is something what endoscopy is also about. So I'm going to talk to you about the history of the endoscopy, why we do it, which indications we have, what kind of procedures, the outside-in technique and the inside-out technique. I'll talk a little bit about the reimbursement and how I do it, and then finally we will make some conclusions. And I'm really glad to have this information shared with you. And about the randomized controlled trial, indeed, it will be at the second half of this year. I hope that the results will be published. So this was in the early 70s, how patients were operated upon their spine. And you can see here that the spine is exposed, the nerves are exposed, the dura is exposed. That's not the way how we operate nowadays. So during the last years, there are several innovations. We have this open microdiscectomy transflaval, which is the most performed procedure worldwide. Then we have the microtubular technique by Kevin and Foley. And then we have the transforaminal endoscopic procedure, which was developed by Kambin and so on, and then adapted by Young and Hoogland. So still today, we see large incisions for simple disc herniations. And these patients suffer a lot of back pain. So we have these two pioneers. My teacher was Thomas Hoogland. He was doing the outside-in technique. And then we have his opposite endoscopic surgeon, Anthony Young, and he did the inside-out technique. Unfortunately, Thomas Hoogland passed away a few years ago. I started to learn the PTED in 2009. And from that point on, I have done for more than 800 cases now, and including the randomized controlled trial. I'm using the Maximor system, but there are several other systems like the T-Syst, the Young system, the Richard Wolf system. That are the most systems that are being used worldwide. Why do we perform endoscopy? There are several advantages, at least in my opinion. The question is, will it be the future's gold standard? If we look at the cholecystectomy in the early 80s, there was a doctor, Dr. Muir, who performed endoscopic cholecystectomy, and he was totally thought that he was crazy, and he was expelled from the surgical society at that time. But today, everyone is performing endoscopic cholecystectomy, and you are crazy if you have to remove the gallbladder via a classical approach. Maybe you will be expelled from the society nowadays. So, but afterwards, Dr. Muir was rewarded for his innovative work, and I believe that it will be the case for spinal endoscopy as well. But we need to train persons, we need to publish our results, and we need to discuss how to proceed in this endoscopic spine surgery. So we have, grosso modo, two techniques. One is the technique which is going into the disc and then taking out the outside part of the disc herniation. We call this technique the inside out technique. And then you have the other technique, which is going into the spinal canal, not touching the annulus, and taking out the disc herniation, which means that you don't have to create another hole in the annulus, and you can remove the disc herniation directly. I call it direct targeting. So why do we perform transforaminal surgery? Because the foramen has several pain generators. We start with the facet joint. The facet joint is well innervated and can create a lot of pain if you have problems. Then we have the dorsal root ganglion, which is also a pain generator. The posterior longitudinal ligament, which can be extremely painful if you touch it, especially if there's inflammation. And then we have the disc material itself, which is toxic. If you inject this disc material into your skin, you will get immediately skin necrosis. So why do I do the outside in technique? Because it's direct targeting. You go where the problem is and you take out the problem immediately. There is no additional damage to the annulus. The recurrence rate in my hands is around 5 to 6% within 1 year. You have better vision to the nerve root and the dura, and you have less post-operative back pain. At least that is what I experience. I did a worldwide survey a few years ago to see how many spine surgeons are performing transforaminal endoscopy surgery. So I got a response rate of around 817 respondents, and they are almost 50% orthopedic surgeons and neurosurgeons. And most responders were from Europe and Asia and Oceania. So if you look at this figure, you can see that the usual care in more than 80% is unilateral transflaval discectomy. If you look at the endoscopic surgery, it's less than 5% usual care. So it means that endoscopy is still in a pioneer phase. But what are the advantages? We have a smaller incision, we have less tissue trauma, it's under local anesthesia and conscious sedation. So if you hit the nerve, the patient will tell you they feel leg pain. Otherwise, they are asleep. Foraminal disc herniations are really far more easy to remove as compared to open surgery. We don't have to destroy the facet joint. There's minimal blood loss, there are hardly any bleeding problems, and in my hands there are fewer complications as compared to open surgery. It can be performed in obese patients. The most obese patient I've been operating on was 150 kg. So you can imagine it's feasible for these obese patients as well. patients have a faster rehabilitation, they return earlier to their work and their daily activities, and there's minimal or no scar tissue. I didn't see any instability in the 800 cases I've performed so far. And you can do also foraminectomy. It's an outside patient procedure, and it's a platform for future intradiscal devices, which can be inserted transforaminally. But last but not least, the patient, they like the operation. They're asking for it. They don't want their back to be opened anymore. So we have also disadvantages, and one of the disadvantages is that the learning curve is steep, meaning this is not see one, do one, teach one surgery. You have to perform several cases to understand what's going on. The patient is awake. You have to communicate with the patient. You need dedicated anesthesiologists or sedation specialists. And realize it's new technology. Not everyone is familiar with this kind of surgery coming from the lateral part into the spinal canal. We are all used to go from the posterior part in prone position. But so far, we don't have randomized evidence-based data to say if it's inferior, as good as, or superior to open surgery. And we don't have data yet on the costs. We know it's more expensive because of the endoscope, because of the equipment you need, but still we don't have hard data to show that. So if you look at the indications, of course, foraminal and extraforaminal disc herniations, but also median, paramedian, cranial and caudal sequestrated herniations is possible. But if you want to start with this technique, I advise everyone to start with large disc herniations in the lateral recess on L4, L5. It's an awake procedure, I mentioned it already, and you need dedicated anesthesiologists. The aim is to keep the patient awake and responsive. If the patient is too deep, you might hit the nerve and patient will not respond. And if patient is too light, you cannot go into the spinal canal because it's too painful. So I always also use local skin analgesia and facet analgesia to make it more comfortable for the patient. So the surgery for me started in 2009, and we had one orthopedic surgeon in the Netherlands who was doing the PTED in a private hospital. And I started to treat these patients also with the technique which I had learned, and then the healthcare system said, well, it's not allowed to do this because it's experimental surgery. And we had to pay back all the money we got from the insurance companies because they told us it was not allowed. So we went to court and we explained what we have done. And first they asked to pay back 250,000 euros. And we didn't have any support yet from the Netherlands because it was still experimental. So we didn't have any clue to say it's as good or better or worse than open microdiscectomy. So we settled the case because the judge said, well, we have done so many cases and the patients are doing well. So let's start a randomized control trial to see what's going on. But up to now, there's still no reimbursement, but we are just about to show our results, and I cannot go into that for reasons of publication, so I have to share that with you another time. But I have my own data, which has been published in 2016, where I did a case series, a prospective case series of 166 patients, and I followed them up for 1 year. The important thing, what you can see in this slide, is that the data is generalizable. If you look, most patients have been operated on L5 as one, which is usually the case in normal life, followed by L4, L5, and 3, 4, and 2, 3. Okay. If we look at the mean age, it's 43 years. male, female, equally distributed. And the mean duration of symptoms was almost 1 year. And if we look at the Quebec disability score, at baseline it was 60, and if we look at the FAS score of the leg pain, it was around 82. So if we look after 1 year, you see that the mean Quebec disability scores going from 60 to 20, which is clinically irrelevant. And the FAS score is going from 82 to around 20, which is also clinically relevant, statistically significant relevant. And we ask all patients, do you recommend similar surgery to other cases? And more than 95% saying yes, we would recommend that. And if they got a recurrent disc herniation, would they go for the same surgery? And 96% is telling they would go for the same surgery. So I did some comparison with some colleagues from the Netherlands, from other studies. This was the study published in the JAMA by Arts and colleagues. And they looked at tubular discectomy versus conventional open microdiscectomy. And if you look at the data, especially if you look at the complication rate, you can see in both the open microdiscectomy as the microtubular discectomy, the rate of complication is far more high than we have. Of course, this is our own data, but we have more than 95% of follow-up. Dural tear, for example, 8% in microtubular discectomy and 4% in open. We had one dural tear in these 166 cases. Most of our cases were same-day surgery. And here it's 3.3 days. So that's a big difference. Today, patients are going, after 1 day, they're going home, but at that time it was 3.2 days mean. And if we look at the recurrence rate, it was 7.2 and 6.6, so it's comparable. So we have performed a large randomized controlled trial of 613 patients who were eligible and 701 who were willing to participate. And we randomized them with the computer system to open surgery or endoscopic surgery. And the inclusion was stopped 1st of April. And now we are analyzing our results, and hopefully soon we can share it with you. So far about the epidemiology and the rates of this kind of surgery. The next phase I want to share with you how I do the surgery. And if you look at the my website, if you go to YouTube and you type in my name, you will find the video which I have shared on the YouTube. Okay, so this is my operation theater. I use a carbon fiber table with a Wilson frame and the C-arm, and the C-arm is positioned so that you have a good AP and a good lateral fluoroscopy. The patients are lying in prone position, and my C-arm, I only have to shift from AP to lateral. I don't have to translate my C-arm. So if you look about the technique, L5 is 1. I go around 12 centimeters from the midline. L4, F5, about 10 centimeters from the midline. And L3, L4, about 8 centimeters from the midline. But these are just general measures. If the patient is thick, you have to go more lateral. If the patient is thin, you have to go more median. So this is how we measure. I have an angle, and I measure 10 centimeters from the midline. This is the equipment I use: drills, rongeurs, and the advantage of the drills of the Maxmore system is that the tip is blunt. So if you touch the nerve root with the tip, the patient will tell you they feel leg pain. You cannot damage the nerve because the sharp part of the drill is 1/2 centimeter, meaning 5 millimeters away from the nerve structures. So if we look at the axis planning, you have a craniocaudal direction of 55 to 65 degrees. You have the lateral direction from 30 to 35 to 40 degrees, and the entry point is always going to the superior articular process. There is where I dock my needle, and from that point we continue to create the foraminotomy and to go into the spinal canal. So important is your patient positioning. If you look and you have good AP and you have good lateral fluoroscopy, then you are sure what you see is what you get. Of course, you have to check your equipment, and then we start with the injection of the skin, which usually takes 2 to 3 cc, and then we introduce the needle, and you can see here, that my needle is docking on the superior articular process of S1. Okay. Once we have entered this point, I use 2 to 3 cc of lidocaine to anesthetize the SAP. Then I use the Tom Sheedy needle to go through the superior lateral part of the SAP to enter the spinal canal. And you have to see that. It is difficult to explain, but you have to understand how you have to enter the spinal canal. Once you have entered the spinal canal, as you can see here, my guide wire is in the spinal canal. The medial pedicular line is here. So we are in the spinal canal, close to the posterior ligament. And that is the place where you ideally want to be if you enter the spinal canal. Remember, once you pass the medial interpendicular line, you are in the spinal canal. There is the place where you can hit the nerve and the dura. So once you have drilled, you go to the second drill, you go to the third drill. Drills we have from 6 up to 10 millimeter. So you can make a lot of space to enter the spinal canal. So once you have drilled, then you put your working channel, and then you go to the endoscope. So the endoscope has 1 working channel and 2 rinsing channels, and we have several rongeurs to use to remove the disc herniation. So here I have a movie of a patient with a lumbar disc herniation on level 4 or 5, and you can see here pre-op the lasag, which is around, I think, 30-35 degrees. And this is what you see. So at 12 o'clock is posterior, 6 o'clock is anterior. We are looking at the right side. So 9 o'clock is cranial. Sorry, 3 o'clock is cranial and 9 o'clock is caudal. The nerve is running from 11 to 1 or from 10 to 2. And you can see that here, the red part, this is the nerve root. And above the nerve root, you will find the facet joint. This is disc material. And the ligament you will find also around 6 o'clock. So you start removing the disc material, and all of a sudden you will see that the epidural space is pulsating. And once the epidural space is pulsating, you can be quite sure that the nerve has been decompressed sufficiently. So, and this is what we remove. So if you look at this, you can see it's around 5 centimeters with a diameter of, let's say, 8 to 9 millimeter. But it's not always that you get this kind of big pieces. Sometimes it's piecemeal surgery, which I will show you later on. So if you see the LASEG immediately post-op. Then you can see it's now okay.
Dr. Harhangi, I think you have to share again the presentation.
Oh, I'm sorry. Let's have a look. Okay.
Yes, now we will put it direct, the presentation. Don't worry.
Can I continue?
Wait a minute. Please try to share again. Now you can continue.
Okay. So here's the post-op LASEG. And you can see it's almost normal.
Gaat het, mevrouw? Nog verder? Nog verder, Alof? Fantastisch, jongen.
So, and if you look at the skin incision, it's less than 1 centimeter. Can you move bigger disc herniations? Yes, you can. But if you do go into the disc, in this case, where you have a large cranial sequestrated disc herniation, you will not be possible to remove all the disc material. So that's the reason I prefer direct targeting. We go into the spinal canal, close to the PLL, we can move our endoscope cranially, and then we can remove all parts which are compressing the dura and the other neuronal structures. So if you look what we have removed in this patient, there are huge pieces of disc material just from one patient, okay? And finally, I would like to share with you one 9-year-old female case, and she was suffering from radicular pain for more than 1 year, and this patient was at another academic hospital in the Netherlands, and they told her it's self-limiting, it will heal itself, don't perform surgery, and we can be quite sure that the problems will be solved within time. But it didn't solve. So the patient came to me and they asked me, can you do PTED? So that's something I didn't do PTED on children. So I discussed it at our staff and at the Erasmus Medical Center, and then we decided to perform the surgery. So this is how this patient was walking, and just have a close look to the way, to the way she's walking. You see, her left leg is a big problem.
Even op de tenen staan, even op tenen lopen, weer terug. Opereren staat er. Ja. En op de hakken lopen, dat gaat niet.
Not possible to walk on her heels.
Helemaal goed.
So this is her MRI. 9 years old and such a huge disc herniation. She has now some contractures on her left Achilles tendon. And parents, they tell me, please don't perform open surgery, do it endoscopically. So we decided to do it. And again, our setup, and this guy is very important. He's one of my sedation specialists, and he was talking this patient through the operation. And it went well. And here you can have a look at her spine. It's very straight. There's a large foramen. And you can see I'm docking here almost on the superior articular process. This is Camden zone. Camden zone is the safe zone where you can enter the spinal canal without hitting any nerve, except when the nerve is axillary, meaning that the disc herniation is in the axilla of the nerve. Then you might have a risk that the nerve root will be somewhere in the Camden zone. So same procedure, have good AP, have good lateral, start to infiltrate the skin and explain everything to the patient. I'm going to do this now, I'm going to do that now. We are going to use the hammer. Very, very, very important. You can see my guide wire is in Camden zone. Okay, I know that the disc herniation is somewhere here and somewhere there. Okay. So the next step is to enter your thumb CD and go to the SCP and then shift to the 4mm drill. And you can see here the tip of the drill is blunt. I'm totally in the spinal canal, on the AP as well on the lateral. Okay, here we are in the spinal canal and here we are in the spinal canal. One might think that you are now in the dura, which is not the case because the disc herniation is pushing the dura away. So then you use larger drills up to 8mm. And once you have created your trajectory, you can put in your working channel, which is shown here. And then I can show you the video how it looks like in a 9-year-old female. So cranial is posterior, 12 o'clock is posterior, 6 o'clock is anterior, and you can see here the white disc material. Some people are using methylene blue to stain the disc material, so you have more an idea of where the disc material is. But once you get experience, you don't need it. You know this is disc material. This is nerve root. What you can see here, this is a nerve root. This is disc material. This is cranial, this is caudal. And you can see that the nerve root is moving now, and it will pulsate. And once it's pulsating, I think you have enough decompression. But this is one of the questions I want to answer also with the randomized controlled trial. So let's see how that will work out. Then if you look at the material we remove, it's piecemeal. The disc material in a 9-year-old in young patients is very sticky. You cannot remove it in a large piece. It's piecemeal surgery. And this is a post-op MRI scan. If you look, there's still some stenosis in the lateral recess, okay? But you don't have any complaints now. So we leave it that way. Maybe in the future we'll get a problem in this part, but then we'll see what we have to do. And this is how she walks after surgery. And she has now almost 3 years follow-up and still happy. So I think we have to conclude that it's something which can be performed in children as well. So to conclude my presentation, as you have seen, we can have very good clinical results. Our patients are highly satisfied patients. More than 95% are happy with this kind of surgery. Most patients do not complain about post-operative back pain, which is definitely not the case in open surgery. At least in my hands, we have a low complication rate. And of course, the results will depend on your diagnosis, first of all, and on your experience with the endoscopic surgery. And here, as I would like to end with my presentation, and thank you all for hearing my presentation.
Okay, thanks a lot, Dr. Harhangi. Then we have time for some questions that have arisen during your presentation. We have one question which is very related with the effectiveness, because how they say, or they ask how to prove the effectiveness of the technique, maybe not only the PTED, the endoscopic technique, to the hospital when they do, let's say, less money or less expensive than the micro open or the open surgery that they are normally used to do. How to do this?
Yeah, for hospitals.
Public, we are talking about public normally.
Yes, for public hospitals, what you have to have is, first of all, good clinical data, which will be available very soon. The second thing, you have to convince them that this is outpatient surgery. Patient go home same day. So you don't have additional cost of in-hospital staying. The next thing is that the risk of complication is lower. So the readmittance of patients to your hospital will be lower as well. But hospitals need data. So you have to convince them with data that is effective and also cost effective. And that will be something which I hope we can prove with our study.
Okay. Regarding with this, you're talking about doing local sedation, always or only in some cases? Which cases you don't do local sedation?
I always use local sedation because the patient will have otherwise pain, which is very inconvenient. So I do skin sedation. Sometimes I do sedation of the trajectory to the SAP, and always sedation of the SAP itself, because I have to go through the SAP.
Okay. Regarding trying to get good results at the beginning for the doctors that start with the technique, we have one question here about which should be the initial cases in your experience?
If you start these cases, I advise to start on big disc herniations in the lateral recess, in which the nerve root is pushed dorsally. Then you are sure if you enter the spinal canal, there is no dura, there is no nerve root, you can enter easily, but make sure that the patient is conscious. Once you hit the nerve, patient will tell you immediately, doctor, I feel it in my leg. That are only two things you need to know, if they have leg pain or if they have back pain, and that's it.
Okay. We have another question about your percentage of reinterventions. How do you do the revisions on these cases?
Normally it's open surgery because I'm still not allowed to do revision cases with the endoscopic technique. But we have some patients who are willing to pay themselves, and in these patients we can do it endoscopically, which is, in my hands at least, a very convenient way of doing it, more convenient than the open surgery.
Okay, and maybe you also said, but there is a question about which is the most effective level. I think the question is talking about which is the best disc to treat.
Well, that depends on experience. If you start, you should start at L4, L5. If you want to go to L5 as one, make sure that the patient does not have a very high iliac crest. But if you ask me which level you can treat best, I think it's most easy in L4, L5, and then followed by L5 is 1, L3, L4, because the higher you get, the bigger your foramen will be, the larger the chance of hitting the dura when you enter the spinal canal.
Okay. There is another question about which is the percentage you operate on old people and young people?
It depends. If the patient has radicular pain with disc herniation, the age is not a contraindication. You can do in any age, from 9 years to 80 years, 85 years you want. But mostly the older the patients are, the more degenerative stenosis they have. And then you have to perform also a decompression, a bony decompression of the lateral recess. And you have to use bigger drills to achieve that. So if there is only a disc herniation with the normal lateral recess, age doesn't play any role.
Okay. Can you operate on stenosis with this technique? There is one question here.
Yes, we have several drills which are smooth on one side and cutting on the other side. And these drills are especially designed to remove, for example, foraminal stenosis, to remove the superior part of the articular process without damaging the exiting nerve root. So
if you use this technique of PTED and you want to do also stenosis, to treat the stenosis, you need to use the broaches. That's your answer, no?
Yes.
Okay. There is another about the learning curve of the PTED.
Yeah.
What's the learning curve, or how can you explain about?
In our study, we did all surgeons. I've trained 3 surgeons in the Netherlands, and all surgeons got a lab course. And after the lab course, they had surgery with me, and they performed around 20 cases together. And then I went to their hospital 2 to 3 times, and I helped them to perform surgery and make them comfortable in their own hospital. And then they started to do surgery by themselves, and we didn't have any serious adverse effects in our patients series.
Okay. We have another question here, doctor, about how do you solve dural tearing?
That depends. You have to be very keen on having a dural tear. Okay. Once you enter your guide wire and you are in the dura, you remove your guide wire, you will see CSF on your guide wire. Okay. that is the point where you have to change direction. Then it will be like a lumbar puncture, no problem. If you do not realize that you are in the dura and you start drilling, then you'll damage the dura and you will have a big hole. You can do two things. Either you pack it with this seal, flow seal, or tacho seal, or something like that, or you do open surgery and you reconstruct the dura. So what I do in the very few cases I had, I put some tissue inside and I closed it, and I didn't observe big problems with that. Well, a few days we had some headache, which is normal also after open surgery, but you have to explain to the patients and you tell them to lie down for 5 days. It will resolve itself.
Okay. There is one question here is telling you thanks so much for the presentation, and is asking what could you do for a cranially migrating L5S1 disc herniation?
That depends how far the cranial sequestration is. If the cranial sequestration is more than half of the vertebral body, you can go from L4, L5, remove away a part of the pedicle, and then enter the lateral recess of the cranial sequestrated part, and then you can remove that part with your rongeur. But if it's less than 1/2 of the vertebral body, then you can go in and close to the exiting nerve root and use some curved rongeurs to remove it.
Okay, thank you. And there is, I think this is the last one. We have no more entering. Although we are talking about PTED, what is the most done technique, the interlaminar or the transforaminal?
Well, in my opinion, the interlaminar technique is just like the tubular technique. It's small. You know your anatomy. You know where to go. You know where your lateral recess is. But most important is when you do interlaminar surgery, you will meet mostly first your nerve root and then the disc herniation. If you do transforaminal surgery, you will meet first your disc herniation, then the nerve root. Remember the slide of the pain generators. Most of the pain generators are in the foramen or adjacent to the foramen. So if you decompress the lateral recess and the foramen from a lateral approach, you will have access to all these pain generators, which is not the case in interlaminar surgery. But most of the interlaminar surgery is being performed on L5S1 because they have a big problem with the iliac crest, which I don't have because I'm using this safe drill system.
Okay, thanks a lot, Doctor. I have no more questions going into, so I think that we can say that it has been a very, very interesting webinar where I think all the audience could have like tips and tricks when how to use this technique of PTED, how to use the instruments and the broaches and how to perform this kind of surgeries. So I would like to thank you in the name of MBA on my behalf also. I hope we can have you very soon in Spain for new congresses when all this is over and we can do meetings.
Okay, thank you so much. It was a pleasure, and thank you for the invitation.
Okay, it was a pleasure for us and for MBA. Thanks a lot, and thanks a lot to everybody assisting to the webinar.
Bye-bye.
Thanks, bye-bye.